Thank you so much, ma'am. And actually, this is actually a wonderful topic, and really needed to put in a lot of thought into it. And I have a couple of ideas while I was hearing all of you, and therefore I would like to share that. The first thing is, yes, it was the global initiative to tackle the problem of avoidable blindness by the year 2020. And this recommends that there should be a secondary level care center for a population of approximately 1 million. Have we really reached there? That's something we don't know. So basically, in a district level secondary center, this is a 30 to 40 bed facility. It is equipped to provide basic ophthalmic OPD services. But this should also provide diagnostic, therapeutic, and surgical services for glaucoma, besides support services. Now, I am always concerned about what is the ability of the ophthalmologist. Are we really training the ophthalmologist correctly in glaucoma? Because if you do not train them properly, they are not going to be able to perform even the basic tasks which are required for the correct diagnosis of glaucoma. So this ophthalmologist who is going to see all these patients, they must have an ability or a facility to improve skills at least every 2 years, so that they can go and have a rotation in a tertiary care hospital where there is an excellent glaucoma setup and keep on improving their knowledge. They must be skilled at applanation tonometry. Gonioscope is an absolute must. Optic nerve head examination with a 90D or 78D. All of us realize that whether if you use a direct ophthalmoscope, you can see, of course, very well. And for screening, it is very good. And if you have nothing else, then this is the best. But if you are coming to a district hospital, you must be trained. The ophthalmologist should be trained with a 90D. Then should be able to read a visual free printout. There are many people who just mug it up and in order to spout out the knowledge in exams, but that is not the thing. The ability to determine, is this what we are seeing clinically? Is this because of glaucoma or is it because of something else? And try to correlate the two. Also, when there is no perimetrist, the ability to go along and get a perimetry done for the patient and properly after explaining to the patient. That means not just knowledge of interpretation, but knowledge of how to get a perimetry done. Next is the person should be good at glaucoma follow-up, and not just follow-up of medical care, but also of surgical care. Because if the ophthalmologist cannot make out what is happening to the bleb, or is the bleb sinking, or is the bleb functional, then it's of no use. So that ability must be there. Able to conduct camps in nearby areas, and therefore, and also in language, which is in very, very simple language, so that people can understand it. Along with that, this type of camps should be not only for the adults, but it should be for college and school-going children. Because if you involve children, remember, you're going to get much better results. I'm not talking about the primary school children, I'm talking about the senior school children. Also, women of the villages, they are the people, if you're able to convince them that go and get an eye checkup done, then as you know, that if you educate the woman, the whole family gets educated. And also ability to train the ophthalmic assistants or the counselors who are there to teach them clinically, as well as the way they are going to use their instruments and whether they are actually catching the glaucomas or not. The next is, what is the equipment required? All we need is a good torch, a good dark room, a direct ophthalmoscope, which has already been said, slit lamp with applanation, and a rebound tonometer, which has been talked about. Pachymeter, I feel, is a must because that definitely helps. We have to have also dilating drops. And then before that, of course, as I said, knowledge to know whether the angle is open or closed. Antibiotics before we do an applanation tonometry. We must also remember to clean our applanation tonometer. These are basics, but often not followed. Viscoelastic solutions should be there. Sterile cotton balls should be there, available in a sterile container, so that you're cleaning at least the tonometer head every time. And of course, sterilium. And these are the international standards have also talked about almost the same things. Of course, they've also talked about whether the patient can have an indirect ophthalmoscope. Indirect, I really don't know. Now, the optometrist, he should preferably come from the same area, because there is no language barrier. He should have good soft skills, good training, and the facility once again for skill improvement. He should be good at refraction, and you can use any one of them. In fact, the simplest is the Priestley-Smith mirror. You can comfortably use it if there's if the streak retinoscope is not available. And amongst all the charts, we must not forget the charts in regional language, besides, of course, dot, loop. Now, what about the perimeter? I'm not going to talk much about the perimeter because it's already been talked about, but the spottable perimeters is extremely good and especially can be used for camps. Next is this, as I said, it has already been talked about, so I'm not going to go into details of it. But what is important is that it can work on a rechargeable battery pack. There is no need for an external power supply, which is a major problem in many of the districts. And when there is community service, that means you're going into the villages, it becomes a problem. The smartphone use also, it has got huge number of apps in order by which we can detect glaucoma. Besides that, it also has apps in order for educating the ophthalmologist and electronic medical record keeping apps. Most of us do not have electronic media, records of our patients. So that is extremely important for us to determine all this. Therefore, I feel that record keeping can be also utilized. Important also is the patient-friendly apps to tell them, okay, now you can use a timer in order to put your medicines, because people keep forgetting. And our basic problem is when people do not adhere to medicine installation, and compliance becomes a problem. Besides that, you can comfortably show them how they're going to lose vision and how their time is going to be, or rather their work is going to be affected because of loss of field. There have to be certain medicines which must be kept in the OPD and certain medicines which must be kept in the pharmacy. And medicines in the OPD I've already talked about, but let's not forget a viscoelastic solution must be kept so that we can utilize it for our gonioscopies. Along with that, paracaine drops, of course, and fluorescein drops in order to take the applanation tonometers. Now, in the pharmacy, besides the usual armamentarium of anti-glaucoma drugs, we must also keep drugs which we know that people get affected because of glaucoma medication in their eyes, like ICOOL, nafazoline, zoline, anti-allergic drugs, antibiotic drugs, because people are going to come with after surgery, then viscoelastic drops, because they're going to have a lot of problems regarding dry eyes because of use of medication, steroid drops, because people are going to be having medicine, have already undergone surgery, and cyclosporin, again, because of ocular surface problems because of surgery. Now, we must also have a minor OT, and in this, we must not forget that besides the normal armamentarium that we have in the laser OT, we must have suture removal forceps, 26-gauge needles, 23-gauge needles in order to give mannitol, sterilium, IV mannitol, IV sets, stand, butterfly needles, a speculum, and most important is we must have a sterilizer. We must never combine our sterilizers with other sterilizers, because remember, our instruments may get infected because it's normally ENT and eye which are combined together in most of our hospitals. That should not be there. If we can have a YAG laser, it's a fantastic thing. Along with that, the condensing lenses for that. We must have consent forms from each of these people, because remember, this is a huge problem. Now, what about the OPD? Now, the attendant or the counselor in the OPD can be a high school graduate who can explain how the patients have to register. He will help in filling a simple ophthalmic form, the history of the patient in which all the risk factors are enumerated, and then also the charts which are there, the patient education charts, which are in the language of the patient, of the inhabitants of that place, if he can explain it to them. Now, once the patients have consulted the doctor and come, he should be available to explain to them how to instill the medication. Very important thing is he must teach them practically on themselves how to instill the medication, how to store the medication in their own homes. And because this is extremely important in order to keep the sterility of the bottles, adequate seating and education charts, which I've talked about. He must have good liaison with the private practitioners. Why? Because oftentimes the ophthalmologist may not be having all the things within his reach, and therefore for urgent investigations, especially for laser treatment for acute angle closure, So he can immediately send. So liaison with the private practitioners in a vicinity of 30 to 50 kilometers, I feel is extremely important. And in a case of endophthalmitis, let's say a person has undergone glaucoma surgery and come and he needs treatment by a VR surgeon, and so it should be readily available. And of course, for a second opinion, which we keep asking. Now, something which we must concentrate on, and that is community-based services. Awareness camps. We used to have awareness camps also in the Armed Forces Medical College, in which information used to be given by means of the television and the telephone to all people. It used to irritate people like anything, but believe you me, we got a fantastic response. We used to reach out to all the units. So when ma'am has talked about the army units, one can do that in order to get people to come along, and a particular form would be filled. After that, after those awareness camps, we used to have so many people coming just because the first time they would come to know that family history is so important, and they would say that, yes, please get a checkup done for us. So these awareness camps, even in a bigger center, are extremely important. The second awareness camps that we have held are in Leh. In Leh, the first World Glaucoma Day, rather not the first, rather I'll say on 13th of March, we had the World Glaucoma Day, in which we invited all the teachers, the police, and everybody who was of great importance in the hill counselors, as well as all the higher officials in the army headquarters, in order to come along, and of course the families which were there, the officers who were there, and to hear about what is glaucoma. In that, we got hold of even the ophthalmologist who was in the district hospital in Leh, and so that we were able to join hands with him in order to improve the numbers of people, to make them aware about glaucoma. Along with that, we used to have camps in the distant areas. In this, I would definitely like to tell you all that there are many places in India, like let's say the high altitude, where there is the facility for digitalization is practically nil. In fact, we would never have the facility to even telephone our near and dear ones because of lack of the internet facilities. So taking photographs was okay, but then after that, what do we do? And then therefore, the thing was that if you can go along and just hold these camps in absolutely far off areas, just take your optome, take a couple of people who are working with you in the OPD and have these camps. So in a village called Taru village, which was far away from Leh main center, we used to have groups of 20 to 30 people coming even in the deepest of winter days, and the entire checkup was done. I hope to publish this at some point of time, where around 140 people, because villages in Leh are very small, very few inhabitants, those over 40 people were all examined in detail, whether ACT was done, the pressure was taken, the optic disc was taken. All these things were done in order to determine whether they had glaucoma. So their awareness about glaucoma also improved. Another thing which is very important is involvement of the school and children and the college children. Have all types of activities, nukkad nataks, competitions for glaucoma awareness, singing, poster making, drawing, use whatever means, but spread the word that glaucoma is a disease which can rob you of your sight. Have village elders, teachers, religious teachers, sarpanches attend all these camps. If we can motivate them, then they are the people who are going to motivate people to coming and getting their eyes checked up. Along with that, regular activities like public awareness talks for local community, and as I said, involvement of school children, even the NCC and the NNS volunteers can be utilized and requested to help in activities to facilitate and creating a bond between the project that you are going for and the local community. And telemedicine, which has already been talked about, this is a great tool, but we must remember that there are many villages and cities not cities, villages and absolutely distant areas in India where this facility is not available. So we have to work upon that in order to think how we can do it. In the district level, as I said, we must have every facility in order to help the patient, whether it is we don't have a large perimeter, even a portable perimeter will help us not only in the hospital, but also in the screening camps. So the other thing is that therefore, the way we are able to lend one hand and go towards the villages, that is the district becomes the center, but these 6 or 7 district eye-level hospitals can then be linked. That means the other hand goes up to the tertiary level hospital. But we all must remember that in tertiary level hospitals, there are huge crowds. Therefore, the ophthalmologist must again have good liaison with the glaucoma specialist, so that he must, inform them that, look, I'm sending so and so person, so that please can you have a look at them. They do not have this ability to stay over there, because we have to think as to when the patient goes to a tertiary level hospital, where is he going to stay? How is he going to eat? Is he going to take, if the lady is going, will a husband be able to accompany her? If the mother is going, then what will happen to the children of the family? All these things we have to think of, and therefore the best way is to expedite the entire process. And in this, what Ma'am Bhadoria was just talked about, in AFMC Pune, people were coming to us from all parts of Maharashtra. So what we did was, the patient was made to undergo every test possible in one day that they arrived with us. So he'll be able to complete the entire examination of a patient. Thank you so much for a patient hearing.